be mindful of the clock. So I was at CVI in the schools for a number of years. Most of my career I've worked in early intervention. I've been in early intervention since 1998. So I've worked with young children, birth to 5, for most of my career. I happened upon a workshop by this person called Christine Roman. She was just Christine Roman at the time, in 2002. And what I learned at that workshop, back then CVI was something we knew about but not very much about. And so I went to that workshop and came home and tried some things with the kids that I saw, and the difference was dramatic, and I've been hooked ever since. And so just voracious reading on the CVI topic, and also for about 10 years I was in a position of doing the professional development for the early childhood teachers of the visually impaired and orientation mobility specialists in my state, which is Illinois. So for about 10 years I was responsible for professional development, and that put me in a position to really need to keep up on the research, need to keep up on what people were saying. So sometimes it's not always research-based, sometimes it's practitioner-based. So, and that has been an interesting place to be in, because it's hard, or it was really hard, to get good sound information on the topic. It was pretty limited there for a good number of years. In the last few years there has been a lot more that is coming out, and so it's hard to keep up with, but I think it's important that we continually revisit what we know and compare it to what we think we know, and you know, that is the process of learning something new, and our field is kind of going through this birth process of learning a new set of skill set to work with this specific impairment. So so that's my background. Oh, I will tell you that today, at the present time, I work at Illinois State University. I am currently the project coordinator for a personnel prep, federally funded personnel prep grant that trains teachers of visually impaired and orientation mobility specialists to work with infants and toddlers. And so they come back for a graduate certificate. They take 5 courses specific to birth to 3 vision, and they complete that program, and they can work in early intervention. At the same time, I'm a student at the University of Illinois, a doctoral student, hoping to be done here in a couple of years and be in a tenure line position instead of just in a grant position. So that's kind of my background. So today what I want to talk to you a little bit of, very quick, is about the changing of the landscape. I'm coming from an assumption that you, as being part of DVI-DB, you probably have a background in vision and probably have a background in CVI, and so I don't want to talk to you about the basics of that. What I really want to get into and spend most of our time on what we know from the research, and then how we can apply that to practice and what people are doing and what they're finding. So we'll spend a few minutes on the changing landscape, and then we'll talk really about the research. So these are really exciting times. We definitely are seeing vast changes. I've been in the field of vision since 1993 and have seen this completely change. I mean, when I was in school, it was not even a topic of conversation, and now here it is. We're finding that a great majority of our kids, or a great percentage of our kids, have CVI, and we need to know how to work with those kids. So we're seeing such a change in our field, and that requires a whole new skill set as practitioners. So we have a real responsibility to our students, to the families, to our field in general, to keep up and know what is best practice. And then there's just such an opportunity for us as researchers, but then also in our practice, to try some things and see what works and see what doesn't. So it's exciting. I think it's an exciting time, and I think things can be quite different in just a short number of years. So we'll see. So I have a picture here of icons from the early 80s. But if you look at the history of CVI, it really wasn't considered a pediatric impairment until the late 80s. Throughout the 90s, there were a handful of research studies that really they were descriptive research, really looking at what is this thing that we're now calling CVI, and what characteristics do those patients have. And most of that research was based in the medical field. And I need to email you. I'll send it to Diane when we get done. I just put together a reference list that you may or may not find helpful, but I listed here on this slide, there's some of the kind of the foundational research pieces that gave us a good idea of what we were looking at when we talk about CVI. So I just wanted to put that in your hands so that you have that for future reference, and I will email it to you afterwards. I've got on this slide, I've got Wong, who did a study in 1991, Jan and Wong, who did another one in 1991, Milner and Gooddale in 1992, they did another one in 1995. They really outlined this whole idea of ventral and dorsal stream. They called it the who and the what system. It was a new concept and something that I think we kind of take for granted now, but that was a new concept not really that long ago. Good Jan Dessa, I'm not sure how you say that, and a whole host of other researchers put something out in 1994. Dutton, who we see a lot from today, came on the scene in the 90s as well. He was looking at just characteristics of CVI and what we see in these kids. So those are some foundational pieces that can get us started. I don't want to talk a lot about the visual system itself, but I want to point out one thing that probably 15 years ago, probably 10 years ago, when I was working with children as a practitioner especially, I didn't understand, but today I think it's something that we as practitioners need to understand. When we're talking about CVI, that information comes into the brain, it has to get through that midbrain area, and then from there back, we're talking about optic radiation. So those nerve endings that are going to the back of the brain, back to the occipital lobe, those are the optic radiations. And I want to use that term because we're going to talk about it a little bit more later. And then it's going back to the occipital lobe. Specifically on the occipital lobe, we're talking about the striate cortex, and that's the back of the brain. So those first portions of the visual system are that dealing with those injury there is going to cause some specific things, and we'll get into that. And then after it goes to the striate cortex, then it is going on that ventral and dorsal stream and going throughout the brain to the parietal lobe and the temporal lobe and the frontal lobe, all those other processing pieces. So I just want to put those terms out there because we're going to get into those in just a minute. So clinical indicators, what are we learning about clinical indicators? Much of the research here is still really medical based, and it requires a lot of wading through in order to put it into what we know in our practice, but it is so important that we have a good foundation for understanding what is being found on the medical side. So some common etiologies, and this list could be really long, but I want to specifically look at 4 because there is research that is informational to us around these 4. The 4 that I want to talk about is paraventricular leukomalacia, and I'll use PVL, cerebral palsy, prematurity, and then hypoxic ischemia. So I'm going to talk about each one of those and what we know, and most of this is fairly current research. So periventricular leukomalacia, which is PVL, is damage to the white matter. When there's damage to the white matter in the brain, that damage is primarily to the optic radiations and the striate cortex. So if you go back to what I was saying earlier, we're talking about midbrain back, striate cortex is that occipital lobe area. The thing to know there is the speculation, because for a while, or really still today, they're not exactly sure why the characteristics that are seen with kids with PVL, why the visual characteristics, how they relate to the actual parts of the brain that are being damaged. So the speculation is that the thalamic radiations, that part of that optic radiations, those thalamic radiations are impacting information as they're getting to the parietal lobes, and that would be part of the dorsal stream. So what's happening is going from that information that's going, it goes to the striate cortex, and then it goes throughout the rest of the brain, and we think of it going to the parietal lobe and the frontal lobe because we think of that dorsal stream. But what you have to realize is before it goes there, it's going back to the midbrain, where it looks like research is kind of pointing to the fact that in that midbrain area, there is some direction that's happening. So that midbrain is kind of taking a air traffic controller, if you want to call it that. It's directing that information. And so the speculation is that, okay, so if the damage is in the white matter, and if it's affecting those radiations, which also is going to affect that center, then that could be why we're seeing some dorsal stream kind of characteristics, dorsal stream dysfunction kind of characteristics in kids with PVL. So that's some speculation. And again, I put the citations there if you want. Oops, I meant to go back. If you want to look more into how or why they're thinking this could be the case. And then I also want to specifically point out Hoyt in 2003 did a study that was quite large. It was retrospective. He looked at 7,200 records of children that were seen in an ophthalmological clinic. 170 of those kids were diagnosed with CVI, and of those 170, 96 of them came back for a follow-up visit, or at least one follow-up visit. That's important because in his study he was comparing what they found at the first visit and what they found at subsequent visits. What he found was that there was that recovery was better in children than adults. So that speaks a little bit to plasticity. It speaks to our potential for recovery. He also found that training seems to improve outcomes. So that gives, even though there's really not studies that say, okay, this practice will lead to this outcome, we can say, he has said overall, when we're doing things, there are outcomes that are measurable, as far as favorable outcomes for vision that are measurable. And then the other thing he pointed out was that the recovery is better when the striate cortex, which would be that occipital lobe, is impacted. So it's better when the striate cortex is impacted than when the optical radiations are impacted. And there are some other studies that are kind of hinting at the same thing. That occipital lobe seems to have some potential for recovery, whereas it's probably that midbrain area that is more difficult to see recovery in. but a lot of that is up in the air. There's a lot of that that's not quite definitive yet. Some other things on PVL is just pulling from several different studies. The impact to function with PVL is there is consistently a decrease in acuity. There's an impact to the field of vision, and it seems to be more often the lower field that is impacted. There is this simultaneous perception, the problem with simultaneous perception, and that is when our ability to see more than one thing at a time. So when we look at a scene, we see a lot of things, and then we have attention centers in our brain, which is a whole different center where we decide what we're going to focus on. So we see the whole scene, but we are able to not look at all of that and just look at what we want to focus on. So people with simultaneous perception problems can't see numerous things at a time. They only see one thing, and that makes it really hard to look from one thing to the other. Now, having been reading all kinds of things that are coming out, I'm seeing more and more about this simultaneous perception, but I have to say, when I was actively a practitioner, when I was in the homes, that was not something I had any idea about. But when I am now learning about it, now reading about it, oh my goodness, I can completely see this in the kids that just in reflection, I can completely see this having been a problem with many of the kids that I worked with. And I don't know, but it seems like this idea of simultaneous perception is maybe not something that is well understood in our practitioners, and I think it's a good piece of information. It really helps us to think about how we present things to kids. They need to, maybe they need to be sequentially presented, one thing at a time, because they can't see numerous things at once. So I think it can impact practice, and we need to know that it is something to look for when you see that PVL diagnosis. Another thing in PVL is not as common, but can happen, is difficulty with facial recognition. Another one is ocular motor apraxia. That's controlling the eye movement. So smooth pursuit, moving from one thing to the other, the saccadic movements, which difficulty with saccadic movements really impacts reading, really impacts watching moving objects. There's also can be impact to movement perception. So again, this idea of problems with movement perception was not something I was aware of when I was a practitioner. And now looking back, I can really see the impact on the kids that I worked with. So they have shown that a handful of kids with PVL and with other disabilities cannot see fast-moving objects. They just disappear. They're not able to see them at all. That would be a good thing to know as a practitioner. We need to know if our kids are having problems with that. The parents have talked about the fact that if their kids have this issue, they don't see, those kids are missing gestures, which impact social skills, impact the system, and being able to gather the information that's necessary the teacher's trying to communicate. And then lastly, orientation. So there's definitely some impact to being able to orient to an environment, find things in an environment. There's visual memory issues, knowing where to look for things. So let me just take a moment to ask and if there's any comment on that list. To me, when I look at that list, I can think back to students that I have seen, and most definitely I see most of those in the students that I've seen. So I'm looking at the comment box. Any comments after this or about this point? Okay. Let me move on. And the other one I want to point out is prematurity. Prematurity, the research is showing that prematurity is susceptible to white matter damage. Well, if you've got white matter damage, then you're going to have a lot of the similar things that you see with PVL. And if you're premature, you may have PVL as well. But the thing to note is even if there's an uncomplicated medical history, they're showing, oops, sorry, I hit the wrong button. Oh goodness, I'm going the wrong direction. Okay, sorry. Even if there's an uncomplicated medical history, kids with prematurity can show deficits in motion processing. That's that whole being able to see fast-moving objects. Or the other thing about motion processing problems is I can be moving and then that lowers my acuity. So that can be a problem in kids with prematurity. It can actually be a problem with kids with PVL as well. Let me move on to the last point. All premature, this study by McIntyre-Bowen, they found that all the kids that they evaluated that were premature performed worse on visual tests than the controls. All of the children. Now, I have to say the things that they were testing were higher level processing. They looked at a lot of attention, visual memory, so kind of some higher level things. But prematurity, even if you don't see a complex medical history, can impact visual processing. Okay, now my looking at cerebral palsy, many of the same symptoms as PVL. Here's something to note. In the new definition of cerebral palsy, visual disorder is now a core symptom of CP, a core symptom. So all of that to say, are these our kids? We're talking about, when we talk about prematurity, there's a whole group of kids with prematurity that have visual processing problems. So is that a visual impairment? And if they call it cerebral visual impairment, then are those our kids? And that's something that our field is going to have to wrestle with. And we have a responsibility as TVIs to know about working with kids with cerebral visual impairment. So this is something I've been wrestling with quite a bit, is where, what's within our domain, or within our practice. How much are we responsible to know about? But then here's the other thing that I think about, that is, if we aren't going to provide that information to the team, who is? Who else has the vision, knowledge to explain why a child that's premature can't see fast-moving objects? So is visual processing our domain? Well, if it's not, who's going to do it? And if those kids only come along every once in a while, and you leave it to the teacher that does learning disabilities, can she really have that kind of a background? So I would love to hear your comments on that. If you don't mind using the chat and giving me some comments, and I'll voice through them. So is it our domain or not? When you make comments, make sure you're making that it's going to the entire audience and not just me or somebody else. Oops. Okay, so Michelle says, where I work, the OTs have been collaborating with the TVIs and the low vision specialists. Yeah, I think that's a really good point. So what do we bring to the team, and what could we bring to the team? That's kind of what I was getting at, is we have a real need to know our vision stuff, because our purpose on the team, or our responsibility on the team, is to bring that vision perspective. So OTs have the motor apraxia. They have they can it's within their training to deal with the eye-hand coordination, those kinds of things. But then there's still a whole host of other things that we should be bringing to the table, I think. Okay, I'm going to move on, but I hope that makes you think a little bit. I hope that's food for thought for you. Oh, Melanie Sargent says, I receive services from a TVI. Don't you legally have to have ophthalmologist diagnosis to provide official services? I've always provided eye strategy suggestions to teachers who have students with visual issues, but visual impairment. Well, actually, according to the federal law, it is not. It's based on function. So the federal law lays out that if vision is impacting education, then they should be getting services. And then there's another piece of the federal law that lays out, I'm not sure the wording of it, but it gets into, we would consider it a learning disability because it gets into reading difficulties, and I think dyslexia is specifically mentioned, maybe. I'm not sure. I could be wrong about that. But we as a profession say you need to have an ophthalmologist diagnosis, but that's not what the federal law says. I don't know, correct me if I'm wrong, if somebody else has another opinion about that, but just looking at IDEA, I believe it's open to function. Anybody else have any other comments? Okay. Diane talks about function. Diane says, I agree that IDEA addresses function. So, I mean, really, this is something we're going to have to wrestle with as a field. What's within our domain? Because and that on the university level, we better be training our teachers to meet whatever we say is within our domain. We better, our personnel prep programs are designed to meet that domain. So this is a question that all of this new research on CVI is causing us to really rethink. Where's the line? What's within our responsibility? Okay, so this kind of gets, so when I think about the role of the TVI and the O&M, I think about rehabilitation, and okay, so rehabilitation or habilitation. Rehabilitation being you had the skill, you lost it, now I'm going to teach it to you again. Habilitation is you never had it, and so I'm going to teach you, and it's going to be a new skill for you, so I'm habilitating. There's a difference there. So call it what you may, and it kind of depends on when the visual impairment occurred and what age group you're working with. But so the TVIs are providing some rehabilitation. We're developing initial skills, we're rebuilding skills that are lost, and we're also teaching adaptive skills, and those are two different things. And it's a big deal with CVI because if the vision is impaired in such a way that we have to teach vision, which is really not something we do with any other visual impairment. But with CVI, we're suggesting we can teach vision. So that's a new role for us as a TVI, to develop initial skills. And if a child is advantageously, if they have, if they acquire CVI, then we're rebuilding lost skills. But then kind of a whole separate thing for kids, we also have to teach adaptive skills, because I'm going to show you in a minute, the research says some kids are not showing progress. So if those kids don't show progress, at some point we've got to teach adaptive skills, knowing that we're not going to be able to, or in case we can't improve that visual skill. So to me, that's a new realm for us. As a TVI, I have always thought of my job as to teach children adaptive skills, not to fix vision. But we're seeing some change in vision. So the other role of the TVI and the O&M is the environmental adaptations and the adaptations to materials, and then to support, equip, and educate the personnel, the other personnel that are working with the child. So we have those roles, but I really wanted to point out the difference between building skills and then teaching those adaptive skills, because I think that's something that's kind of new with CVI. It's a new way to think about it. Okay, brain plasticity. There is evidence for rehabilitation, and it's kind of slight in the world of educational research, but the medical research is starting to give us some support for our assumption that we are actually changing the way a child sees. So there's evidence that an enriched environment leads to accelerated learning, and there's two different studies on that. It's the same group. I think the same group published twice on the same piece of research and from two different perspectives. But this research is not in humans. So realize that they're looking at mice actually for this enriched environment. But there's other evidence for that. So if you look at the last bullet point, Roman Lanzi in 2010, they recorded improvements in 95% of their study participants. What they were looking at, and it was over several years, they were looking, and she used her CVI scale, measured kids, and was able to show progress on those indicators in 95% of the participants. Now, you have to realize there's limitations. Those participants they traveled across the country, they chose to come, so you had motivated people, they probably were going home and really doing the things, but regardless, that enriched environment showed gains. So that gets back to that, are we changing vision? It appears that we are actually improving vision, so that's a different skill set than what we've done in the past. There's some evidence that the latent pathways are awakened to overcome when sight is lost. And this gets a lot into, there's some evidence that the occipital lobe, really that striate cortex, will take on different responsibilities if it's not used for vision. So that adds to our understanding of plasticity. Just so that stuff is happening. There is some new ideas about sensitive periods. And so there's this research by Lewis and Maurer, and it was specific to vision, and they were looking at the fact that, well, let me go to the next slide where I've got it laid out for you. I kind of took the information and put it in this chart, and the detail, I don't have all the details in this chart, but so they looked at several different pieces of our vision, and they were able to show that there is a period when so let's talk about acuity first. There is a period when acuity normally develops, birth to 4 to 6 years. I don't think that's anything new to any of us. We know kids, by the time they're in kindergarten, their acuity is pretty much at adult level, but it's not so when they're 6 months old. So it progresses through about 6 years old, then they reach adult level. But here's the new piece of that. So what they found in their research was that children are susceptible to damage that is not recoverable. And okay, so in acuity, specifically between 10 days and 10 years, and they were looking at kids with cataracts. So if a child developed a cataract within that damage window, even if they removed the cataract, there was some permanent damage. Whereas if they had the cataract prior to 10 days and were able to remove it before that 10-day mark, there was no damage. And if they got a cataract as an adult, we know you get a cataract, as an adult, you remove it and you're fine. But there seems to be this window of damage, and their theory is that, okay, so you have this normal development, but then between 6 years old and 10 years old, there's some extra kind of setting in of that acuity systems, so that it's not really susceptible, it's not really free from being damaged until you hit 10 years. So if that makes sense. This research was really interesting if you're interested in this kind of thing. Then the other thing that they found was there were some things that were, there were certain pieces of it that they were able to recover up to certain ages. And so then there's this additional recovery window. But completely changes our idea of what we know to be the window of recovery. So it's not just or sensitive periods, I mean. It's not just one sensitive period. There appears to be different layers of this sensitive period that impacts plasticity. And they only looked at these 4 areas: acuity, light sensitivity, global motion, and asymmetry. But their hypothesis is you would be able to see this same kind of layering to all kinds of different pieces of your vision or any other skill. I mean, they're kind of speculating that this could probably apply to many areas. They just tested the 4 areas. So that was new information to me. As I'm working with kids, though, this is good to know. How huge is my responsibility to providing an enriched environment if I'm working with children that are in the early childhood age range? And let's say I've got a child that is 12, 13, 14 years old. I need to consider adaptive training if plasticity, if we can't recover vision. And I don't know, the research isn't for sure saying we can or can't recover vision, but it's something we need to look into. It's something we need to know more about, because we need to know how that impacts our work with children. Just some more things on plasticity. There's evidence that plasticity is not available at later ages. Here's another interesting piece. There's research that is showing, and I put one down here, but there's other pieces of research that strengthen this a little bit more too. There's research that talks about the impact to vision when you add motor. If I remember right, I think this piece of research also got into the need for active involvement and not just passive involvement. So I think we have some understanding of that with our kids that go through patching and the need to be actively involved when they're going through patching. But this study in particular was actually looking at the architectural change within the brain. And so they were able to see that there truly was some structural changes within different centers of the brain if you included motor in the learning. And because it was a structural change, that held on. So they went back a year later and were able to actually see that in place. So that's important to know also with our rehabilitation, is if we do it today and they're able to get the skill, then can they hang on to that skill for some time? And there appears to be some evidence for that when it's related to motor. I don't know about other things. Okay, so the rehabilitation efforts are meant to improve our vision, but we can also teach adaptive skills, and I kind of already alluded to that. I want to point out 4 different pieces of resources we have. They're not so. Lewick and Dutton have their new Vision in the Brain book, and they have a lot of ideas for rehabilitation in there, a lot of strategy ideas in that book. Many of them are not based on research. They're based on assumptions from research, but it's going to be helpful as we work with children to know those. I also wanted to point out this study by McKillop and Dutton, and it was published in 2008, It was a survey that they, or focus groups that they did with parents, asking parents what strategies they use with their children. It was such a rich study to read. I mean, the information as far as strategies that might work in the classroom, I think are pretty profound within that article. Roman Lanzi, and I'm talking about Christine's book that it's the one that she published in 2007, Cortical Visual Impairment, an Approach to Assessment and Intervention. It's chock full of strategies. A new book that I almost didn't buy, but I finally did because I wanted to see what was in it. It was a phenomenal read. It's by Zeal and Dutton, and it's called Cerebral Visual Impairment in Children, Visio-Perspective and Visio-Cognitive Disorders. There is a section in this book that is all about strategies that we can use with kids, and it's almost medical based, but the ideas I think could be applied to, and they're meant to be applied in a variety of settings, and they say that up front in the preface of the book, but they're very different than anything that we've thought of or used before. I think probably because it's not from the United States, it's a little different perspective on things. It's a worthwhile read, especially if you're working with if you're training others. I think it's a good perspective to bring in. I would love to see some of these things researched a little bit more. They have some of their ideas have single case studies that give some credence to what they're saying, but I mean, they say right at the beginning, some of these things are not founded, that we don't have research to back them up, but they're worth, logic would suggest that these may have some impact. So, you know, it's all new frontier. So a lot of these things they need to be researched further. But that book was new to me, and it had some ideas that I'm anxious to go and try with some different kids. I'm going to talk a little bit more about some of the ideas later as we go. I'm watching the clock. So all of this, to me, in our functional vision evaluation, when I was seeing kids with, when I had an active caseload, my kids with CVI, I was not focusing on visual acuity. I was definitely focusing on field, but I wasn't focusing on visual acuity, and I don't think I did enough with contrast. There's all of these extra pieces that I think it's important that we make sure we're really paying attention to, because it should and it would impact our rehab. I was probably showing things to kids that they couldn't see just because of their acuity. I was just too far away, or they were too small, or too detailed. So, and as we're making environmental adaptations, that information is, I mean, you know, we use all that with kids with other visual impairments. We need to use it with kids with cortical visual impairment as well. Gathering that information in some of our kids might be a little bit more difficult, but in the Lueck and Dutton book, they have some ideas about how to get some of that information out of kids that have multiple impairments. So that's a good resource for that. So in the next section, I'm going to take you through 3 or 4 different impacts to vision. Certainly not taking you through all of the impacts to vision with cortical visual impairment, but I want to take you through a few that I found the research to be eye-opening to me on. So things that I just hadn't realized before, and some newer research. So visual acuity, that's a big one for me that I really think I glossed over with CVI, and there's a lot of research on visual acuity in kids with CVI. The damage to the striate cortex can impact visual acuity. Well, a lot of our kids have that area impacted, and so visual acuity is impacted. We see this in kids with PVL, with CP, with prematurity, with hydrocephalus, so it's going to be pretty prevalent. It's not as prevalent in higher functioning cases of CVI, so those kids that are on the more mild end of CVI probably have less visual acuity impact. They've found that acuity can improve spontaneously with maturity. So if you go back to those sensitive periods, maybe it has something to do with the sensitive period. I'm not really sure. I mean, they didn't give a reason for it. They were just comparing different age children and said that acuity can definitely improve with maturity. So it's something that we would have to revisit again and again with children. Visual field, damage to the optic radiations and or the striates can impact the visual field. It just so happens that the area of the optic radiations that deal with our lower field tend to be the area that is more often damaged, and that's why we see this lower field neglect, or it's usually neglect rather than complete loss, but this lower field, that's why we see that so prevalent in our kids. It has to do with the area that is more often damaged. They've found that fields can improve over time. Well, I'm saying that because I'm taking that from Roman and Lanzi, who showed 95% improvement over the kids. So I'm taking some liberties with that study, but if we can improve, Roman Lanzi, when they using her 10-point scale, if we can improve those things over time, then that would be something we want to work on. So specifically, Dial and Dutton are suggesting that we should be aggressively trying to improve the field of vision. And so they talk a lot about helping kids use their visual search by taking things from where we know they can see and out of their visual field so that they will look for them. That would be a way to improve visual search. And then the opposite, putting things on the perimeter of their field in order to help them start to pay attention to the neglected field. So both of those two different strategies to help two different skills. One would be more teaching of a skill, and one would be more of an adaptation. That searching is an adaptation, whereas the improving neglect of a field would be teaching a visual skill. Lower field loss is common, and it causes difficulty with safe navigation, and also kids look clumsy when they have that lower field loss. Color and contrast. I'm kind of speeding through. I just have a few more, and I want to make sure I get done in these last 10 minutes. Color and contrast. Contrast needs time to recover, and it seems to improve with age. So again, something for us to be aware of. We need to consistently be checking contrast in our kids so that we are providing the contrast that is necessary, but realize that it can change over time. Okay, this study by Good and Howe in 2006, I think, is one that we really need to pay attention to. They found that children with CVI tested better in lower luminance, and they were looking at VEP scores. But this would suggest, we use lights with kids. This study is suggesting that perhaps lights are not an end-all be-all, or you can't just assume that's the way to go, that we really need to pay attention to what lighting level the children perform best in. And in their study, if you read the conclusions, they specifically talk about the impact to how we work with children, because lower luminance may be better for kids with CVI. Now, in their study, they tested kids with other visual impairments, and the kids with other visual impairments did do better in higher luminance. But kids with CVI had a level, they reached a ceiling level with their tolerance of light. By the way, on one of the studies, I think it was by Dutton, talked about there's a whole grouping of kids that have photophobia, so that's something to pay attention to as well. you've probably read the Cohen and Mater study, or Cohen, Mater, and Hyrick, I'm not sure how to say those, from 2005. So they specifically studied color preference and movement preference, and they systematically tested each one. And what they found was if something was moving and colored, children looked at it longer than something, or preferred it over something that was static and colored, and that was better than things that were moving in gray, and that was better than things that were static and gray. So I'm taking some liberties with my with the way that I've laid this out here, but they tested one against the other, and overall there's definitely this preference for moving, and the color, maybe it's because color increases contrast, I don't know. There was definitely a preference for color over just gray. What they did find, though, is there was no specific color preference. And so this is in direct conflict, I think, in what we think of as just our professional wisdom. We assume there's going to be a color preference in children with CVI. I challenge you to test this with your kids. I have to say that I did, when I was working, I worked with a lot of kids with CVI when I was active in practice, and I commonly found that if I didn't go in assuming they liked one color over the other, if I would just stand back and objectively test it, that I really couldn't see a color preference. So I find it interesting that there is a study that shows there's no color preference. Some kids, I have to say, I did find a color preference in. So I don't know. This was an interesting finding to me, that they were not able to objectively find a color preference. Facial recognition. There's differences in the area of the brain that are for familiar, and actually in this study they used the mother's face. So differences in familiar faces and unfamiliar faces. So there's some implication there for, yes, a child may be able to recognize his mother, but he might not be able to recognize that unfamiliar people are unfamiliar people. In other words, if you just show him a random face, he might not know if that's somebody he's supposed to know or not. So there's different parts of the brain that deal with the way we catalog faces. And the face area is definitely different than objects and shapes, but also familiar and unfamiliar are different places. Now, can we teach facial recognition and expression? Because these are important. These have important social implications. There was a case study by Lamb, Lovett, and Dutton, and it was a single case study. The child was, I believe, 9 in the end, but they had him all through the years, and they were unsuccessful. And they systematically tried to teach facial expression. Unsuccessful. In the Zile and Dutton book, they actually describe a program, a 3-step program, starting out with object recognition, then going to facial perception, just is this a face or is it not a face, and is this a familiar face, and then they get into the highest level of their program is facial expression. So am I happy, am I sad, kinds of things. And they actually cite 3 different researchers who had success teaching different components of facial recognition. One was primarily taught by the mother in the home. So it's interesting, and it's something to think about. Can we teach recognition of faces? And if not, we need to adapt for it, and that is having familiar people wear things that, colors or things that would make them recognizable. But if we can teach facial expression, that would be really helpful for language, communication, and social. So interesting study and interesting thought. Simultaneous this is looking at two things at once. It's believed to be an impairment of attention, which is a specific part of the brain. Specifics are part of that higher level processing. It seems to be associated with visually guided movements. So if you have a hard time looking at two things at once, you also may have an area of the brain damage that helps you to look and read or use those lower limbs. And then several studies have pointed out that this is a problem, and so I just want to point out that it's really something that we should be paying attention to in testing in children. And in the Lewick and Dutton book, they give them some specific ideas for how you could test for this in children, and then some strategies for dealing with it. Okay, I think this is my last slide. Motion perception, I think I've talked about this one already, but there's some citations for you to look at. Some kids have problems seeing fast-moving objects. Some kids have problems when they themselves are in motion. Their acuity actually decreases when they themselves are in motion. So again, something to know about our students, to test this in our students, and then if it's an issue, we need to make adaptation for that. Oh, okay. This one is probably my last one. Visually guided movement is an issue also. So I'm looking at the time, and I told you I would get done on time. So just kind of a final challenge. I think all of this is to say we really need to make sure that in our functional vision evaluation we are incorporating areas that we know could possibly be a problem, because we need to then plan our programming in a way that we're either teaching the skills or we're teaching adaptations. And then we definitely have to be able to communicate that with the team. If we can bring something valuable to the team, we show our worth, we help the child's situation, we're providing information that people probably don't have. They don't have a good history, it's not common, so it's not going to be something that they have history with. So we have a responsibility to know about CVI, know the newest things that are out there, and have a good toolbox for working with these kids. So it is my time zone, it's 1 o'clock. So I am to the end of my time with you. I thank you for your attention, and I'm going to I will send through Diane, I'll send the PowerPoints, and I will also send just a reference list, just so you have those all in one spot, and I'll send my email as well. And I am quite willing to stay on for a few more minutes if anybody has any questions for me. So thank you very much.